Good afternoon. I'm Dr. Philip Spencer. I'm assistant professor of surgery here at Mayo Clinic in Rochester, Minnesota. I'm a cardiothoracic surgeon, and I specialize in heart and lung failure, mechanical support, and transplant. Welcome to our series. Today, we'll be talking about extracorporeal membranous oxygenation, as well as other forms of acute mechanical support, and specifically strategies to support patients in cardiogenic shock. It's my great pleasure to introduce my dear friend and colleague, Dr. Ada Bafar. He's a professor of medicine here in Rochester. He's a cardiologist specializing in heart failure as well as interventional cardiology. Ada, thanks so much for joining us, and I'll hand you the floor.
Sure. It's a real pleasure to be with all of you today. Um, as we go through, if you guys do have questions, I encourage you to use the chat box to put some questions in, and either Dr. Spencer or I are happy to address those. Just some disclosures here. Learning objectives, as Dr. Spencer mentioned, we're going to go over some of the mechanical circulatory support devices today and review how they can be used in cardiogenic shock as bridging therapies. And we'll really look at how these are deployed in a guideline directed way and how we decide what type of device to use in different individuals. Most of the effort here today will review how with ECMO, we offer venting strategies. In other words, in order to make sure that the patient is maximally optimized in the setting of mechanical support, we have several different approaches that can be taken, and we'll review those with you, as well as show you some of the hemodynamic rationale behind why these different approaches are utilized. A thing to remember about patients in what's called acute decompensated heart failure or cardiogenic shock is that a clinician has numerous opportunities to try and intervene in these patients. And often a systematic approach is needed to ensure that the correct line of therapies and sequence of therapies are offered to achieve the best outcome for these individuals. Often those outcomes mean that we successfully bridge them and preserve other organs so that they can undergo something like transplant or LVAD implantation. I don't know if Dr. Spencer, you had any other thoughts on this?
No, I certainly agree at this point. Thank you.
So one of the ways that we like to break down acute decompensated heart failure is really to define how the patient is presenting. What we see in heart failure, we can utilize a what's called a pressure volume loop descriptor, is that when you have a cardiac event or you have a decline in muscle function, the contractile force of that muscle starts to diminish. And so the heart has to remodel, it has to grow in size in order to be able to supply the body with the same amount of blood volume per stroke, or what's called a stroke volume, as would be if the heart was healthy. And so often these patients are living on the brink of volume overload because their heart is really stretched to the max in order to offer this stroke volume normalization. And so often in heart failure, the first way that these patients present is what's called warm and wet. What that means is that they've pushed their volume to the max, but they're still supplying their body with sufficient amount of stroke volume. And for those patients, we simply just diurese, get rid of this excess volume, and we vasodilate. And so when we look at this pressure volume map, what that does is it simply brings the patient back away from that end volume type of scenario and provides stroke volume advantage, because by vasodilating, gain some stroke volume by offloading the pressures that the heart has to beat against. That's typically just a inpatient visit with some IV medicines, and the patient can go back to their normal regimen. However, if these patients show up as cold and wet, it means that now the heart no longer can supply the adequate amount of stroke volume per beat to nourish the other organs, right? So you may see kidney failure, you may see change in mentation, you may see livers that start to fail. And so for those patients, we first start with a strategy that leverages inotropes. Inotropes are medications that enhance the beating function of the heart in order for there to be a normalization of stroke volume. So on top of what's done with the warm and wet patient, we add now a new IV medication to try and get the heart to beat harder and beat stronger. This is sort of the beginning of cardiogenic shock, and really where we often get involved, Dr. Spencer and I, are when patients are cold, but now they're not wet. They're actually dry and cold. This means that despite the fact that these patients have had optimal management and have been well diuresed, their heart cannot sustain blood flow any longer to nourish the rest of the body. And there's nothing we can do on the medication side to any longer improve things. And so here, what we have to do is artificially augment stroke volume. And that's done now. And it's depicted here with a massive swing in stroke volume. But now we're using mechanical circulatory support devices to try and rescue these patients. If we do see warm and dry patients, obviously those are not cardiac, and we call our friends in internal medicine to take care of those individuals. Usually those are more septic patients. So driver for mechanical support has increasingly been something that we call extracorporeal memory oxygenation. And this is where the heart and lung function of the body is essentially replaced by removing venous blood from the patient, putting it through a circuit that oxygenates and enhances the flow of that blood, and putting it back in through the arterial system. This is often done peripherally. And when it's done peripherally, it essentially creates a counterflow to that which the heart normally would be used to. And so what we get is something called increase in afterload. And in an already struggling heart, what happens there is that as you increase afterload, in contrast to what we typically do with heart failure, you get a precipitous drop in stroke volume. And so this can create some difficulties for the patient in that blood flow that is going to the left side of the heart can no longer make it out into circulation and may get backed up into the lungs, causing pulmonary edema. And this is really one of the main challenges we have. I'll pause here and see if there's any elements that Dr. Spencer wants to interject across the last few slides.
No, I think that's really helpful, Dr. Ford. And I just want to also put out, if you have questions out in the audience, please use the Q&A, not the chat, because we can see those, and feel free to specify whether you have surgical or medical questions. But I appreciate this. This is kind of the key area of discussion now, as we see patients who may not benefit as much as we think they should from VA ECMO and shock. And our question is, are we unloading specifically the left ventricle enough for the heart to recover? And I appreciate you kind of giving us the hemodynamics behind that.
And so what do we do in this scenario then, right? So we have this heart that is now struggling already to begin with. We make the decision to replace heart and lung function on this machine, but now we're above and beyond what we were seeing originally. We're now further compromising the stroke volume function of this sick heart. And so the first approach, and this works for hearts that actually still have enough preservation of stroke volume and enough myocardial mass to be able to mount an increase in stroke volume, we can use inotropes. So we can go back to the drugs and actually augment stroke volume using simply an IV drip to try and get the LV, the left ventricle, to accommodate this increase in force that it now is seeing from the ECMO device. So that's number one, and that's probably the most straightforward, easy approach. But often it doesn't work because these left ventricles are quite sick. The second approach is a device that is called an intra-aortic balloon pump. What the intra-aortic balloon pump does is it counterpulses with the systolic function of the heart and actually dramatically drops afterload. So while the ECMO circuit is enhancing afterload, the balloon pump can serve to offload afterload. And so with inotrope, you may get enough stroke volume benefit with a balloon pump, which is low profile, low French size, easy to put in, and have these patients successfully tolerate ECMO devices. When we bridge patients on ECMO to transplant, often what we like to do is ensure that they can engage in what we call prehabilitation efforts. In other words, we want these patients to be able to maintain or even regain their strength now that we've normalized their circulation as they wait for a destination therapy such as LVAD or transplant. And so what we've done with regards to balloon pumps is we've leveraged an area of the arterial anatomy where the third portion of the axillary artery actually comes out from just underneath the anterior deltoid and allows us to gain percutaneous access. Using this anatomy, we've been able to put these balloon pumps not in the leg, which renders the patient bedbound, but actually in the arm using the approach that you see in the picture. And we're able to maintain these patients and prehabilitate them because they retain ambulatory prowess. And when we put these in, we do actually see significant improvement in the cardiac index. In other words, the stroke volume of the heart is indeed significantly improved and may be able to counteract the afterload burden of the ECMO circuit. The second approach that is utilized for patients on ECMO-based support is something that we call an ECPella strategy. Here is delineated some of the older devices that have been historically deployed, the Impella 2.5 and Impella 5.0. Today we have Impella CP and Impella 5.5 that are typically utilized. The Impella CP we typically put in the cath lab, and it's often done actually prior to ECMO placement in trying to support a patient who's having a heart attack. The Impella 5.5 is put in surgically, and Dr. Spencer is our resident wizard in putting these in. And we often use this device as a standalone device or as a device that is deployed to offload the heart from the burdens of the ECMO circuit. So in a nutshell, this is what the two different devices offer. The intra-aortic balloon pump offers a diminishment in afterload, and so you get stroke volume benefit. And so sometimes the heart can survive ECMO circuit burden. With that approach, the Impella directly evacuates the heart using a motor. And by evacuating the heart, we again alleviate the burden of the ECMO circuit on the left heart and can reduce that on the heart. And so maybe, Dr. Spencer, you can take a moment to just share with our audience the surgical approach that we use here at Mayo to put these in.
Sure, thanks, Ad. I appreciate that. So much like the femoral placement of the balloon pump versus the axillary in Impella, the CP is a device used now. It's smaller, and it's often put in percutaneously, or always put in percutaneously via a femoral artery. And it does limit ambulation, but it also doesn't quite have the same ability to fully offload the heart with its maximum circulation of 4 liters per minute. And that is really pushing that device. It is generally going to survive that patient 14 days or so, the CP. And after that, it may generate thrombus. It may fail. It may cause hemolysis. The 5.5 is a slightly bigger pump, and it does need to be put in surgically. I do this with either a right or left axillary cut down underneath the clavicle and expose the axillary artery, isolate it with proximal distal control. And I use an 8 millimeter gel soft graft in an endoside fashion. The company recommends a 10 millimeter graft. And if you're using a HemoShield, that's what you'll want to use. The gel soft graft has somewhat larger inner diameter to the HemoShield, and an 8 works nicely, especially if you're working with some smaller patient. And that graft is tunneled out of the skin underneath the incision. And then you can use that access through a sheath with a drum on it to across the aortic valve with a wire, and then place this device with its tip, as Ada has in his diagram here, away from the mitral valve apparatus, pointing towards the apex of the heart. And then it works incredibly well to offload the heart. And in many cases, I have used this to fully support cardiac output, even in full-sized adult men, 6 feet tall, 200 kilograms. And so it can be a very powerful device. We have used it here with a maximum of 3 months without complication, not willingly, but that's what the patient needed. And so it works very well and can essentially provide you full LVAD support as a way to unload on VA ECMO, but also as a way to bridge off of VA ECMO if the patient only needs a left-sided support. One downside is that if you're using femoral VA ECMO and you're using Impella as a vent, it can make you, it can give your patient a little bit higher risk of what we call Harlequin syndrome or North-South syndrome. If they have pulmonary edema or sick lungs at the same time, you can increase the ejection of poorly oxygenated blood from the left side of the heart, causing hypoxia of the coronary arteries or the right side of the brain hemisphere. And you may need to onload either a venous line for oxygenated blood insertion onto the right side of the heart, or use a different strategy that Dr. Bufar, I think, let's talk about a little bit later. Thanks, Ada.
Absolutely. One thing while we're on with you here, there was a question about the afterload impact of central versus peripheral ECMO. I've highlighted here the peripheral ECMO, but I thought from a surgical perspective, you could highlight the central as well as the pros and cons of why we often go peripheral.
Thank you very much for that question, because I get this question a lot, and I think it's important to understand that central ECMO does not change afterload, because you're still injecting the blood under pressure on the other side of the aortic valve. So it creates the same afterload. It's just directly in the aortic root, which the heart will see, rather than all the way from the leg or the axillary artery or something like this. So it doesn't actually change that. You still need a vent with central ECMO if your heart is not ejecting well. What it will do is eliminate that North-South syndrome or Harlequin syndrome, because you're injecting the oxygenated blood directly above the root. And so that it will avoid, right? But it doesn't change the situation of afterload. That's a common misconception. It will give you, it's not retrograde flow from your leg. It is to the head, the arms, the body, the natural flow. But as far as the left ventricle is concerned, the afterload is the same with peripheral or central ECMO.
A little bit about right-sided support. Indeed, in some of our patients, beyond having left-sided failure, we do see a need at times to support the right side, either in isolation or in tandem with left-sided support. This is particularly the case if we are using something like an Impella 5.5, where we don't have offloading of the venous system through a circuit. Two commercial devices that are often utilized. One is called the Protect Duo. This is essentially an ECMO cannula that's dual lumen, that's positioned at the distal tip uh, in the pulmonary artery, and then as you come back, there are ports that start in the right atrium and go all the way up into the SVC. Comes out of the right internal jugular vein, typically. There's also an Impella RP Flex. This is their newer device that's come out. It can be really put in either through the leg, as shown here, or can be put in through the upper uh, IJ or upper extremity, like the left subclavian. Both of these devices are quite expensive. And at Mayo, we, in particular during the pandemic, did come up with our own version of this where we simply just use two cannulas um, for a much, much lower price and are able to achieve the same sort of phenomenon where we just put single lumen cannulas through the internal jugular vein and then a multi-stage venous limb for drawing the blood out. So this is just a different approach, but very similar to the other. The other approaches that can be taken for venting include directly venting the left ventricle through the left atrium, actually. So here we describe the ECMO circuit that is coming through the subclavian artery, and then the venous is leaving through the IJ in this cartoon. And through the leg, you can actually put a transeptal cannula that sits in the left atrium and draws blood out. So really the left ventricle is left to see almost no blood. This is very similar to the tandem heart approach that had been previously utilized, and it can be called either LAVA or JAVA, depending on who's describing it. But essentially, this is direct left atrial venting plus the veno-arterial ECMO that is typically put in. So here we essentially offload through direct venting, and the venting cannula is then Y connected to the venous limb, not the arterial limb, obviously. And this is what it would look like on transesophageal echocardiogram. The other approach that we've developed here at Mayo is something that we call PAVA. In PAVA, what we do is we actually vent past the pulmonary artery valve. And so essentially we're grabbing blood that is destined for the left atrium, but in a much less invasive and easier to position cannula. So we often go through either the right IJ or the left subclavian. We position our wire like you would with a right heart cath in the pulmonary artery, and then pass a typically a 17 French single stage cannula up into that limb. And again, Y connected with the venous circuit to pull blood out, and all that oxygenated blood goes back through the arterial line. So there was a question about could we provide with a graphical description of what an ECMO circuit looks like. So here what we have is a description of direct left atrial venting, Y connected to the venous limb, and then the ECMO circuit going back into the arterial limb. We've done this in numerous patients now. We both using the pulmonary artery venting approach as well as the jugular access venting approach, or the LAVA approach. And with these approaches, we actually have seen a significant diminishment in lactate levels. So this really does work to offload the heart quite quickly. We can get normalization of cardiac index. And although most venting approaches that we've described today provide similar mortality advantage over the first 10, 15 days of therapy, if these patients are meant to or need to go out much longer, we do see survivorship advantage through use of venting within the ECMO circuit rather than outside of the ECMO circuit. So what we see in this left atrial or PA venting approach is really an elimination of blood from the LV. So you have essentially less than 1 liter of blood for stroke volume at the left ventricle level. And most all of the blood is now gone into the ECMO circuit. As Dr. Spencer mentioned, this north-south syndrome or Harlequin syndrome is also addressed with this approach, because now the left ventricle really has almost nothing to eject. And so the exogenous blood that's coming through the arterial limb has a bigger opportunity to fill the arterial circuit. So here in summary, what we showed is that you have different types of patients presenting in cardiogenic shock. Once you get to that cold and dry patient, mechanical circulatory support really is the only approach that needs to be considered. In the setting of ECMO, numerous devices that can also be used autonomously can be deployed. Those were in the form of inotropes or intra-aortic balloon pump. These are for slightly healthier LVs that can mount some ejection fraction or some stroke volume on their own. Next, the Impella device that can be utilized essentially as an ECPella approach, or a motor that offloads the left ventricle, or as we showed now, a percutaneous venting limb either in the left atrium or in the pulmonary artery to vent all of the blood away from the left ventricle. And lastly, just to mention a few right ventricular approaches that we can use if really a biventricular requirement is needed. So now I'll pass it back to Dr. Spencer to review a case that we shared together.
Hey, thanks a lot, Anna. I really appreciate it. I just want to say one more thing. Dr. Bafar really pursued this PA venting strategy, and I commend him so much because it's become a great strategy that I use for our patients. And another neat thing about it is he discussed the idea of right-sided support. And sometimes we get to a point where we've done PA venting, our LV has recovered, or we've used another device like an Impella, and you can reverse that circuit, or you continue to drain from the RA, and you can inject back into the PA. And now what you've created is an RVAD that is essentially a dual lumen version of the Protect Duo, or there's a few other companies that make such dual lumen or right ventricular support. So that's just a neat thing that he really came up with, that you can change that flow pattern without changing anything with your cannulation and go from a vent to an RVAD. This is pretty neat, and I thought that was really, really quite brilliant. All right. Well, thanks a lot. We're going to go ahead because he and I shared a patient together that I think is a nice example of a number of these strategies that we'll take to present. So we'll go to my disclosures slide. I don't have any for you. And I'm going to present this young woman. There's a 30-year-old woman who presented to our emergency department in clear cardiogenic shock, really the very end stage cardiogenic shock, the kind that happens before you die. She's dry, incredibly cold, hypotensive, and becoming unconscious, really losing her mental status. She's very small, very malnourished, and really a classic cachexia that we don't see too often anymore. And one of our colleagues was available, and he cannulated her quickly in a near ECPR, or a near arrest event, in our emergency department with a 23 French long multi-stage venous cannula that had its tip in her superior vena cava, and a 15 French, given her size, short arterial cannula in her left common femoral artery. And he used a large distal perfusion in the superficial femoral artery, also on the left, to help perfuse her leg, again, given how small she was. And he was able to restore full hemodynamics for this young woman, and she arrived into our cardiothoracic ICU. She carried with her a diagnosis of something called congenital propionic acidemia, something I had never heard of before, where she would become very sick with propionic acid that's present in almost every food, any food containing protein. Her sister had died at a very young age, 12, and this young lady had persisted having periods of wellness when she was incredibly rigorous about what she was eating, and other periods where she would become very sick. She had briefly been on a transplant list at another institution, but had recovered and come off that list. At the time she presented to us, she had a massively dilated left ventricle. Her ejection fraction was calculated at about 12%. She had a mildly large right ventricle, but still pretty severely reduced RV function. And given the dilatation of the left side of her heart, she had severe mitral valve regurgitation that was predominantly functional. Here you can see her chest X-ray in the initial stages of her care. Meet with her venous cannula here in her right atrium, and this is an early echocardiogram showing the severity of her LV function. It is just almost not moving. So the first thing we wanted to do for her was initiate nutrition support. There was no way at her level of cachexia and disability was going to tolerate any kind of heart surgery, any kind of operation at all, to give her a durable answer to her problem. And furthermore, we didn't know what exactly we could do anyway at that time. We were able to implant an Impella 5.5, which you can see here. That case really taught me that even in patients as small as her, if they are young, that axillary artery can stretch. The company will suggest that at 7 millimeters, you can put one of these pumps in. Hers is just over 5 millimeters, but given her young age, the artery could stretch. And once I was able to get into her ascending aorta, the device fit fine. And that worked to vent her LV and allow us some thoughts of what could we do next to support her as we rehabilitate her. And our goal was to try to get some of these cannulas out of her legs, particularly her arterial cannulas. Both of her internal jugular veins were stenosed due to many times in her life having PICC lines and other central venous access for the purpose of TPN, as she had been ill throughout her life. So I could not get access for a PA, either vent or RVAD in either jugular vein or subclavian artery. She was surviving on this PICC that she had presented to us with. That's what she had for central venous access. And so we were able to obtain, I believe it was from Medtronic, but it may have been McKay, kind of an extra long venous cannula that's single stage. So we went to her contralateral femoral vein and were able, with a balloon wedge catheter, I'd have got this in, to float this up above her pulmonary valve. And through that, we were able to wean her off of the ECMO. We transferred the arterial limb of our ECMO to this pulmonary arterial catheter, and we created an RVAD. So we had drainage from the right atrium, return into the pulmonary artery, and then left ventricular support via the Impella 5.5. And we were eventually able to wean her off of ECMO, i.e. this RVAD, with a oxygenator, eventually to none at all with a central mag. And so her lungs are able to oxygenate. We can support her right ventricle with the 2 venous cannulas and her left ventricle with the Impella 5.5. And so 6 weeks of prehabilitation ensued. She had a feeding tube, and she got a very, very specifically designed formula by a nutritionist and by our genetics team. That team got involved and told us that with this particular disease, the enzyme deficiency is in the liver. And if we could transplant a liver for this young lady as well as a heart, we would be able to bridge her to a near normal life. She'd be a transplant recipient on immunosuppression, but she could eat a normal diet with a normal liver. And so that was our goal. And we were able to list her in that way. We were able to get her to a pretty borderline BMI of 18 to 19, but certainly better than the just under 15 that she presented with. And after 2 months of the initial ECMO cannulation, we got offers for both heart and liver and proceeded with transplant. The donor was just a little bit older than our recipient, brain dead donor. We had a relatively straightforward case with a bypass time of 173 minutes and total heart ischemic time of 233 minutes. And there you can see the end of the case, her x-ray with some chest tubes, but no more cannulas and no more mechanical support. This is just a little video of the heart at the end of the case. That is pretty proud. The thing was just incredibly healthy. So at 1 year, she was on sirolimus-based anti-rejection, which is another technique we use here at Mayo Clinic, trying to help prevent antibody-mediated rejection. She had had one episode of grade 1R rejection without AMR that was well treated. She's living independently in her community. And most importantly, she is consuming a normal diet that would probably approach, maybe a little healthier than mine, but approach all different food groups, which for her was an incredible achievement in her quality of life and raising her children. So it's something we're pretty proud of, but I think will demonstrate a number of the different techniques that we use here for patients in severe cardiac shock. Thanks, Anna.
Thank you. That's I think that was a very nice case that we shared together, a great outcome for the patient, and a wonderful depiction of how these devices can be systematically utilized and changed to support someone as a bridge to transplant. If in the Q&A there are additional questions, we would be very happy to review them.
Well, we're waiting for some. I'll just throw this out. If you're thinking between a left atrial vent and a pulmonary arterial vent, and your goal is durable LVAD versus a transplant, it affects my decision on that. HeartMate 3 LVADs are not. They don't work well if you have any kind of a right to left shunt. The patient will turn blue. They'll suck the blood, and so it can add a procedure to close the defect in the right atrium, even if it's small. That needs to be closed at the time of LVAD. So if you would like to choose between your LA vent and your PA vent, and your end goal specifically is LVAD therapy, I prefer the PA vent. It's one reason why I think it's such a great innovation, and it works almost, if not in many patients, as well as an LA vent, which is a bit shocking, frankly, because you're draining pre-capillary instead of post-capillary. So it amazes me every time we use it that it works as well as it does, but it can be incredibly effective.
Yeah, I wholeheartedly agree. And in fact, I would say that since the first time we've used the PA vent, I can't think of a single case where we have gone back to use a left atrial vent. And as you highlighted, it's in the setting of LVAD, it's very nice because if we struggle with the RV, you simply switch the flow of the limbs and you have a built-in RVAD.
Right. You don't even have to do anything. Just leave them there. Yeah, it's great.
Yeah, exactly. So I think, yeah, I completely agree. I think we are working towards having a single venous access type device. Those will be a little bit more, will have to be put in with more interventional support. However, it does afford a arterial sparing approach, and those hopefully we'll be able to share some news about them in the coming years. Just check to see. All right, we have a new Question. This is a question about our patient. Are both organs transplanted simultaneously? If not, how do you decide which organ goes first? And how long is needed for optimization prior to second organ?
That's a great question. Thanks. So in the vast majority of these cases, if not all, the organs are, particularly in heart, liver, are done in the same operating room setting. The vast majority of heart and liver combined transplants in the country are going to be done with the heart going first because the heart is less tolerant of ischemic time. And so you want the minimal amount of time out of the body from the donor to the recipient with the heart. The liver can tolerate cold ischemic time better. That is most of the time when you're not worried about other immunologic factors. So you'll implant the heart, get the patient off bypass. The liver surgeons will implant the liver, and then they will close the abdomen. And then the last thing would be to close the chest because you really want to make sure that's dry and you're not flirting with tamponade. That's the vast majority of cases. That's what was done in this instance. In some more rare cases where we have a significant, we call it PRA or sensitization, the patient has a lot of antibodies to donors out there. The strategy is to do the liver first because the liver will desensitize the patient to the antibodies and then put the heart in. That takes a lot of careful timing. It can be done by moving quickly or using donors that are very nearby, or we can use an ex vivo perfusion device to perfuse the heart while the liver is being implanted and then put the heart in. But that is really an immunologic strategy over a strategy like this, where we were trying to treat two separate diseases that were related, or be it the cause of her heart failure. But in general, they come from the same donor and they're done at the same operating room setting, but we can't do them at exactly the same time.
And I'll just highlight the heart after liver approach was actually pioneered here at Mayo Clinic by Doctors Daly and Kushwahab, who led the way about a decade and a half ago now. Was the first one that I think they've done. There's another question about Impella and Ecpella and reduction of hemolysis risk. I think you highlighted that the biggest risk to hemolysis comes from the Impella CP, much more than we really see ever with the Impella 5.5. In my experience, at least, we haven't seen much of any meaningful hemolysis with 5.5. In the vast majority of cases, it does happen once in a while, but with CP, it's almost a guarantee.
At some point, you'll get it with the CP if you really try to bridge the patient for a while. With the 5.5, the times I have seen hemolysis, it is a clue that something is wrong with the pump. And the 3 times I've seen it out of, I don't know, maybe 80 times I've put it in, it's been thrombus on the pump. And so when you see it with the 5.5, you should get very suspicious that you need to exchange that pump because you have ingested thrombus within it. It doesn't just happen because the pump is very gentle on the blood cells. With the CP, if you're running that pump 7, 10, 14 days, you'll see it just because the pump is running at a high speed for a long period of time, and the products of the hemolysis are starting to become clinically relevant. But I have not seen it with a normally functioning pump yet in the Impella 5.5.
There's a couple more questions that just came through. In PA venting, how do you manage the oxygenation deficit from the venous admixture? For example, if a patient has a high BMI and lungs were contributing significantly to oxygenation. So I think what we typically do with PA venting is Y connect the PA to the venous limb of the circuit. And so that blood all goes through the oxygenator before it hits the arterial side of the circuit. And so the blood actually gets preferentially oxygenated the vast majority of the blood in circulation is then withdrawn from the body, oxygenated, and then put back in. And in fact, with that much draw out of the heart or the cardiopulmonary circuit, that north-south phenomenon is even overcome in the vast majority of patients. I don't know if you had anything else to add there.
Yeah, the addition, and this may be related to the viewer's question, is that what you do is you're now emptying the heart nearly, and you need to flow high because now all of the circulation is going to be provided, or nearly all, by ECMO. You're not going to have a significant contributor from your heart. And so you want to flow at a liters per minute that's going to come near or better than a 2.5 index, all from your ECMO circuit for that patient, because now all of the flow is going to be ECMO, and very, very little will be a contribution from the heart. So the lungs will not be contributing anymore because the left ventricle won't be contributing anymore. And so you're now essentially on bypass without a reservoir.
And the nice thing about having the two venous cannulas is you can really pull much more and flow much more.
Yeah.
This is for you. It's about the OCS device. Do you see outcomes improvement with OCS? And is Mayo doing normothermic perfusion strategy for transplant? And what are the risks or benefits associated with that?
Fascinating. Yeah, go back. Dr. Clavell and I did a piece on transplant where we do talk about this, and I'll indulge a little more. Yes, we are using the TransMedics OCS device, which is the only FDA approved ex vivo or ex situ perfusion device for the heart. And we use it in two scenarios: when the distance from our recipient is really far. So if we suspect over 6 hours ischemic time from a brain dead donor, we will use that. We will use it for many donation after circulatory death donors to bring the heart to the recipient, as it's one way to resuscitate the heart, the other being normothermic regional perfusion. And there are differences in donor centers as to which one we would use, and as well as differences in distance. And actually, the last one is what we talked about. On a handful of occasions, we've used it because we know that time may be of essence while we're doing a heart after liver case. And it may be a difficult liver transplant that we think would take longer than we would like to leave the heart on storage. I will say we're using it less for distance now than we were 2 years ago, with research coming out of Toronto showing that organs stored at 10 degrees instead of at 0 to 4 degrees have performed better for longer periods of time. And that is proven to be true. And so rather than using TransMedics OCS, if we expect our ischemic time to be more than 4 hours, we'll use it if we expect it to be more than 6. The reason for that is it is a bit more complex to implant the heart on the OCS device. If there's any problem with that device, the heart is warm, and that transplant's not going to happen. I haven't seen that happen, but it can, at least theoretically. And over long periods of time, the heart can become edematous on that device. So it's not a forever pump. You don't want to put a heart on that device, go to bed and say, I'll do it in the morning. That is not happening. That's not what we think about. It's just that here in Minnesota, if we have to go to Washington State to get the heart that is appropriate for our patient, that would be a lot more comfortable than necessarily cold storage. But yeah, we're using it. It's proved helpful in a number of different ways. And it's just fascinating to see how the technology, both for supporting our patients as well as preserving our organs to bring to those patients, has changed even over the relatively short amount of time I've been doing this.
I think in your answer, you also embedded the answer for the subsequent question, which is, what is a typical and safe ischemic time? I think you sort of addressed that. So
on ICE, the data says no more than 4 hours, but that is absolutely changing at 10 degrees. We're not sure. There are institutions that have brought hearts back 9 hours at 10 degrees on cold storage. So that is going to be over the next year, I think, kind of um, investigated more. And we may have an answer that is both surprising and luxurious, if you will, really allow more organ sharing around the nation.
A question about LV and root thrombus formation in non-ECPella type or central ECMO type approaches, especially with PAVA. If we worry about LV thrombus or root thrombus when we deploy that. In my experience, we haven't seen it. In fact, the few times that I've seen root smoke, sort of initially with just VA, peripheral VA ECMO, we saw that with the PAVA approach over time cleared. I don't know if you've seen that or not.
Um, I have seen root thrombus in 2 cases, and I'll say it is a risk anytime you have a situation where the heart's not ejecting, and so using the Impella device will lessen the risk for this over Pava, Lava, or even a balloon pump where the heart doesn't eject. And for those of you out there using a balloon pump, make sure you put the balloon pump on standby because pulsatility on the balloon pump does not equal heart ejection. Separate issue. But yeah, the key thing is if you are in a situation like that, you have to be very careful about holding anticoagulation. The times I've seen it have been patients who are post-operative, post-cardiotomy, and anticoagulation is held due to bleeding issues, and then we've suffered from root thrombus. So those are the patients you want to be really, really careful about. And I've seen it both in one centrally cannulated patient and a separate time in a peripherally cannulated patient. So I do not think that central cannulation protects you 100% from that problem if you cannot anticoagulate.
So this says, what are some of the tips of cannulating at a community hospital so that you can transition to an advanced center? Maybe I can start and maybe chime in. Definitively, cannulation is rarely done in a controlled setting. And so you need to identify key individuals that develop a high degree of acumen and expertise in doing this in a chaotic environment. And so people that are often well versed in vascular access or percutaneous vascular access should be trained to do this. We do here at Mayo offer a training course on porcine models so that people can become well versed in how to cannulate and also how to put someone on an ECMO circuit. But definitely, yeah, you do need some rigorous training and practice. I don't know if you have other thoughts.
Yeah, and also the more support you get, the better. So I would say if you're not even if you're less experienced, period. If you can use imaging, you will be safer, and that is true for me. That is true for Dr. Bafar. That's true for anybody. So I think Dr. Bafar was leading towards interventional cardiologists with access to a cath lab, surgeons with access to some sort of imaging, either through fluoroscopy. We routinely use transesophageal echocardiography, even if we're in the ICU, someone will drop that. I have had situations in the community where I've got to cannulate where somebody who's skilled at transthoracic echocardiogram has been able to give me an image of the right atrium to at least assure we have wires and cannulas in that place. Because there's no doubt you can kill somebody by putting a wire through the vein, putting the cannula buckling and going through the vein. Sadly, I'm sure most of us who do this enough have seen these things. And having a team of people who could support each other, it isn't a one-person job. Somebody's got to hold the cannula while the other one is securing it so that it doesn't go flying across the room, etc. but it can be done in the community well. I think having a somewhat multidisciplinary team involved, particularly perfusion, probably an interventionalist, and if possible, a surgeon, cardiac anesthesiologist, somebody else well versed in access and management of sick people, particularly people in cardiac shock, is helpful. And that's also helpful to have a nice relationship with the tertiary center that is gonna transfer these patients for you, so you can get them on, have a plan, maybe even a joint decision making process, and then off they go to folks who have an ICU that's going to take care of them over the long term.
One additional question that just came through is why does the CP have a higher risk of hemolysis compared to 5.5? I've always thought that it's a smaller profile device, and we often run it much faster than the 5.5. The flows that you're trying to get the smaller device to achieve often not going to give you the type of benefit that you want. It's meant to be a temporary device around stenting procedures, not necessarily hemodynamic support. And the smaller lumen really does beat up the red blood cells. It's just not very forgiving compared to the 5.5.
Yeah, put simply out there, it's way more revolutions per minute for the same flow. That's
Exactly.
it.
I think we answered all the questions, and we really appreciate your attendance and your attention. Wish you a good evening.
Thank you so much, Anna. Thank you so much for your time, and thanks
Thank
everybody
you.
for participating. That was fun.